Hi everyone, welcome back to this week's Fertility Q&A. We are going to be joined by Dr. Kenneth Gelman of IVFMD, and we are looking forward to answering your questions. So we have another round of fertility Q&A questions regarding IVF or getting pregnant naturally, what to do actually to help increase the success rates of any cycles you're going through, and also in general, just questions about anything that comes to your mind. Feel free to jump in and get those questions answered. Dr. Kenneth Gelman works with IVFMD, and he's located in Cooper City, although they have offices in several different areas. And I've actually worked with him for many years. He's super knowledgeable with so many things, especially PCOS, and he's worked with our patients over the years with all kinds of conditions. So he will be joining us soon. I'm going to wait for him to pop in here. And let's see here. And also, we have had some of you submit your questions before. Oh, I see him right here. Okay, so let's see if I can get him on. But if you didn't have time to get your questions in, go ahead and type them in the chat. We'll be able to answer them tonight for you, for sure. I hope everyone's having a wonderful week.
Hello.
Oh, there you are. Hello.
Good evening.
Nice
Good evening. Good evening.
Oh, I just remember my volume is a little low. Let me turn it up. Okay. So can you hear me okay?
I can hear you fine. How you doing?
Perfect. Okay. Let me turn up my volume here. Awesome. So hi, and thank you guys for joining us. We are having a great week so far. It's Wednesday night, and we're here with you to answer all of your questions. My name is Farah Duro. I'm a licensed acupuncturist, and I specialize in reproductive acupuncture. I'm licensed with the American Board of Oriental Reproductive Medicine, and I've been working with fertility patients since 2004, so a long time, but really trying to help maximize the potential for increasing success rates with IVF, IUI, or helping with a natural cycle in general, or also just improving hormones with PCOS, endometriosis, many things like that. So, and Dr. Gelman, if you can introduce yourself to those of you who do not know him.
Hi everybody. Happy New Year. It's the first one since last year.
Yeah, right? I know.
Yeah, I'm Kenneth Gelman. I'm in the Cooper City office with Dr. Wood and Dr. Gerkowitz, and along with 9 other doctors and spread out all over IVFMD. Great practice, and we're here to help you, and I hope I can answer some of your questions tonight, and we're excited to be here.
Very cool. Thank you so much. And we actually have had some questions submitted beforehand.
Right.
I want to get to those first, but definitely don't be shy. Everyone type in your comments below, and we'll be able to get to them as well tonight. So let's get started with jump right in. This is a question that we actually talked about last week with Dr. Wood a little bit. We talked about, is there a possibility that you have like too thick of an endometrial lining? And her take was that it wasn't, that it's okay usually to have a thick lining. But this question was, is a higher endometrial lining thickness correlated with a higher implantation success rate? I know there's a minimum lining number needed before a frozen embryo transfer. Is being on estrogen for a longer period of time, does it increase the lining and lead to a higher success rate?
Not necessarily. It's obviously a good thing to have a thicker lining. But, I think, there's been, things that people have been looking at thin linings too, in terms of this. And I remember at the ASRM meeting a couple of years ago, it was 2 meetings ago. It wasn't last time. It was the time before that. The people, actually the fellow who invented the ERA test, endometrium receptivity assay, was giving a talk. And I happened to be there, and we happened to ask those questions there at the end of the talk. And people who are familiar with the endometrium receptivity assay, it's a test. Well, it's part of a mock cycle that we do for frozen embryo transfers. We set up a fake cycle just to sort of see what their lining does and how thick it goes, and how it develops. But, during those during that cycle, all we're essentially doing is looking at your estrogen level and measuring your thickness. It doesn't tell you anything histologically. Is there all the bells and whistles needed there for implantation, which apparently they've figured out now with all these scientific studies. They've looked at all these implantation proteins that should be present. So the ERA test looks at the influence of progesterone and the development of these implantation proteins. And his answer in terms of what the lowest end of the thickness would be actually 6. So everybody says it should be 7 and over, and probably is certainly better, but certainly below 6. Now nobody's ever really said anything above a high end. There's never been anything I've seen that suggested that your lining shouldn't be over 15 or 16 or anything like that. Okay. So and the estrogen part of the cycle itself is variable in a lot of women. The first part of the menstrual cycle typically can be all over the place. It can be very short to very long. Mm-hmm. It's the second phase, the progesterone phase of the cycle, that's very exact. Okay. So nobody's really shown that. So I don't know whether, having an estrogen lining of 15 for, 2 weeks more is going to cause implantation any better than somebody who has it for 7 days.
Okay, very good. Yeah. So it doesn't mean that you should continue estrogen for weeks and weeks and weeks to get that.
Well, usually you're on some kind of protocol that, your practice has given you that you should be on estrogen for a certain number of weeks. Right. Before you start your progesterone, so I don't know what specifically they're doing there, but, it should be part of a protocol, a specific amount of time.
Okay, awesome. There is another question we have that this person is prone to yeast infections, and she's asking, can this affect me getting pregnant through intercourse? For example, does the infection prevent the sperm from fertilizing my egg, or does the infection affect the pH of the sperm? Also, does having a yeast infection at the time of the frozen transfer affect the outcome of the transfer?
Yeah, I mean, those are good questions. I think that would. So certainly, you got to make sure your bacterial cultures are negative before you start your frozen transfer. We do that. We always do bacterial culture looking for yeast infections or vaginosis, things like that, which obviously can be correlated with an abnormal microbiome. That's the new term now. Abnormal microbiome in the vaginal compartment, which theoretically, could be seeding into the uterine compartment too. I mean, that's the big theory now. And they actually have these biopsies that in genomics is promoting, called Emma and Alice, I think their name. They give them a fancy name. But they're actually looking for abnormal microbiome in there as indicative of implantation failure. So much like the ERA test was invented for people who have failed a frozen embryo transfer, now they have this test for abnormal microbiome where the patients undergo these endometrial biopsies, actually in the endometrium, to look for abnormal bacteria. So
an endometrial test or like a vaginal?
Endometrial test.
Okay.
It's a biopsy. It's an endometrial biopsy.
Mm-hmm, yes.
So, obviously abnormal bacteria and abnormal microbiome can affect implantation. So there's these tests now. They're looking for that. So I would say yes, that infection could be causing a problem for either intercourse or certainly for a frozen embryo transfer. I would not do the transfer if you had a yeast infection.
Not to mention miserable. You want to get rid of that.
Well, sure, but unfortunately, sometimes they're asymptomatic too.
Probiotics, right? Like oral probiotics.
Yeah, as part of our frozen protocols now, we're adding vaginal probiotics and oral probiotics, in order to prevent all this kind of thing from happening.
Okay.
So it's a very important part of what we think is included or imparted in implantation. So implantation is a complicated process. So it probably involves a microbiome to a certain extent, obviously, creating the right pH and the right environment.
Very cool, because I
Yeah.
wondered about the type of probiotics that you use and that sort of thing. So we had a question about that. I think it was a couple weeks ago, and that you guys will provide a certain type of probiotic, I think, for your patients.
Yeah,
So,
yeah, it's actually a vaginal probiotic.
mm-hmm. That's
Yeah.
so that's
Yeah.
just for frozen transfers, or it could be for fresh as well, or
Well, frozens. We don't do a lot of freshes anymore, fresh transfers anymore. So,
okay,
but frozen transfers, because, that's what's so good about frozen transfers. You can prepare.
yeah,
You really can prepare the endometrium. You can prepare ahead of time. You can do these mock cycles to really know, to the best of our ability. It's not 100%, but it's really increasing the odds that things are right before you transfer this beautiful embryo that you've worked so hard to create.
mm-hmm.
So it makes a lot of sense to start looking at things proactively instead of everything, retrospectively, kind of thing.
That's why you guys are so thorough, and it doesn't compare with when people get, they go perhaps out of the country, they go somewhere else, and they're like, wow,
Yeah.
the gift that I had out
Well,
there was like nothing like this.
well, I mean, obviously, if it works, you can call them a genius, But
Yeah,
when it doesn't work, and the people come to us for second opinions and things,
yeah,
and you kind of scrutinize what they've done, there's certainly areas for improvement. And while maybe we get criticized that we delay patients too much, because we're too concerned about their weight and what they eat, and things like that. But I think it makes a big difference. It really does.
right. In the scheme of things, like a couple months is not really that long. I mean,
Well, we don't think so, but we got to really try to keep people on track. It's very hard to
yeah,
keep them on track. People get discouraged. They lose motivation. They want everybody wants things done yesterday,
yeah.
and that's just unfortunately it's getting so complicated now, and so much more precise that we can improve things better. That if things are not correct, we should definitely work on them ahead of time.
And it does take a little while to see the differences in egg quality. Like we talked about this before.
Yeah.
I mean, for those little follicles that have been marinating in all those antioxidants, it can take
Correct.
5-6
Yeah.
months to actually start to
Yeah.
see the results of all of that hard
Yes.
work. And so,
Yes. Yes. Don't forget. And I always say this to patients that health is part of this. It's not just here. When we're creating these embryos, we're putting them in there, getting pregnant. Yeah, that's what we're doing, but it's all related to your health too.
yes.
So that if you are not healthy, and your blood vessels are bathed in, inflammation. I mean, what do you think is going to affect your eggs? I mean, it's the same blood that goes from your heart, from your coronary arteries all the way down to your ovarian arteries and your blood flow there. So it's the same thing. Inflammation is going to affect your egg quality.
Yeah, no, that's for sure. And so I think we could do a whole separate Q&A on inflammation, but I know
Yeah.
you have a question, so I'm going to keep
Yeah.
going.
There's a lot of them.
Question on the chat: does diet affect fibroid growth? As we're talking about lifestyle issues, how would you answer that?
Fibroids?
Does diet?
I mean, I'm not really sure that anything's really going to affect that. I think maybe probably a high fat diet, probably if you're making more hormones in your fat tissue. Certainly if you're overweight, you probably, shouldn't be feeding any extra weight with any high fat foods. So maybe from that perspective, but I think, fibroids more likely are hormonally active, could be hormonally sensitive, so that, things that affect hormones maybe could have caused those things to change in size more.
Give up meat, and they done better. I mean, I think maybe they were eating a little bit heavily on the red meat before. Maybe it wasn't organic, or who knows. So they actually went vegetarian, vegan for a while, and saw some differences with their cycle and all of that. So
maybe, but I think it's more hormonally dependent, and maybe you're getting hormones from meat, those kinds of things. Maybe that's where the organic comes in. But I don't know whether that's really been shown to be an issue. I think fibroids are, all about location, and obviously if they're in a bad place, they're going to cause symptoms or cause problems. So
they don't grow back. That's the thing. You don't
as
want
long as they don't grow back, yeah. Yeah.
Okay, and so there's a question that we had earlier in reference to endometriosis and sedimentation rate. If the sed rate is high, would it cause infertility, low AMH, etc.? Also, is the high sed rate due to the inflammation from endo?
Who knows? I mean, sed rate is a very non-specific test. You don't know what that's from. I mean, that could be anything. So I wouldn't say it's endometriosis. Maybe it is. Maybe it isn't. Arthritis does that. I mean, typically there's, certain medical diseases cause very high sed rates. So, I wouldn't say only endometriosis is doing that. I mean, CA-125 maybe is elevated in what we think is deeply infiltrating endometriosis. So, maybe that's more of a reliable thing to look at in conjunction with symptoms. And maybe, if we see an endometrioma in the ovary, something like that. But normally I don't look at sed rates in terms of endometriosis. I mean, that's not something I typically do.
I've heard of that. Well, I mean, they correlate, but it is inflammation after all. So basically the high sed rate due to the inflammation, that's what they're asking from the endo. But we don't, again, you don't know where it's coming from.
Yeah, you don't know where that's coming from. A sed rate is very non-specific, but I mean, if you're looking at inflammation in general, yeah, maybe a sed rate is one way to look at things, but also a CRP, HS-CRP is probably a better test for that.
Awesome. Okay.
It's more sensitive.
Okay, and I guess, talking a little bit about, we talked a little bit about Letrozole, I think, in some of our Q&As, but this question is, does Letrozole help thicken the uterus lining?
Well, it will. I mean, if you get a good response out of it, and it usually, if 5 milligrams is the average dose. I mean, if you get a good response and you get a good quality follicle, you'll get a good thickening of the lining. So it'll improve things definitely over, potentially clomiphene, which, might thin the lining after 3 cycles or so. So, Letrozole is my preferred drug.
So, I mean, it goes back to progesterone, because if you have a good follicle, it's going to help. A healthy corpus luteum is going to produce.
Correct. You'll get a better progesterone production, as an indicator of the first part of the follicle being formed properly.
And that progesterone continues to thicken the lining and those sort of things.
Correct.
It helps with implantation for sure. So
yeah.
And what do you think is a good progesterone for someone that has ovulated, who's getting tested at like day 21? Like, you want to see it like 10?
Usually 15 is what we usually use.
Okay. Yes.
Yeah.
Okay, and does a DNC after miscarriage harm the lining? A lot of lining questions today, so
yeah. Well, that's a big thing. Well, it depends. I mean, depends how rough the DNC is, who's doing it, how experienced the doctor is who's doing it. Could absolutely potentially harm the lining. I mean, not so much these days anymore, because I think doctors are pretty well trained and they know about that kind of thing. But, in the old days, we used to have a lot of probably more frequent problems, Asherman's syndrome, which is, scarred up lining, possibly from a rough DNC or two. But, sometimes DNCs, even though they're not rough, they may miss things. So you have retained products anyway. So that's why it's always important after a miscarriage, a couple of months later, to have an SIS study to make sure your uterine walls and cavity looks good, that there's nothing left there. Okay.
Yeah, and that comes up a lot about DNCs. So, and
yeah,
we were talking about things.
But they're, look, when we do it, when our doctors do it, they're very careful. We never see any problems. And obviously we get products at conception, chromosome analysis on the tissue. So it's a useful procedure. And it also, it sort of alleviates the concern about, is it chromosomally normal or not, to a certain extent? Is there other causes of this miscarriage? And also the patient, can move on rather than wait for the tissue to expel on its own, maybe.
Yes, we hate to see those, but it is a fact that sometimes we have to help with someone going through a DNC and to help that cycle start to normalize and also help with the emotional pain of going.
Yeah, it's a tough thing, but it's sometimes better to do it. And I always say to patients again when these things happen is, it's better now than later. If things aren't meant to be, it's always better when it happens earlier on, so you can move on and do this again, because you will get pregnant.
Yeah,
You already shown you can.
definitely.
So, and it wasn't meant to be. It's just that things are so scrutinized, in our field that it gets a little harder sometimes. But unfortunately, women have miscarriages all the time. Sometimes they don't even know that, and they've
Right.
had it.
Yeah. But we're here to make it happen.
Yeah.
Well,
Yeah.
so let's see. We have another question regarding failed FET with a PGS tested embryo. Would you recommend an autoimmune panel? Good question.
Yeah. Those are always good questions. Yeah, because you always have to look for other things. I mean, I would definitely do an autoimmune panel looking for also what's called a thrombophilia panel, looking for any clotting disorders and things like that that may not be detected. And the autoimmune panel should obviously look at natural killer cell function as well as phospholipid antibody panels and ANA, things like that. The thrombophilia panel looks at all the tests of clotting and prothrombin gene mutations, things like that. That maybe you're not aware yet you might have, so we can pick up things that are potentially treatable.
Yeah.
Because that's always a tough question, because you never know what the problem is sometimes, because while the embryo is deemed chromosomally normal, is it really truly chromosomally normal?
Mm-hmm.
We don't know that for 100% either. But it's the best thing we have to go on.
They're about how accurate are these?
Well, they say 98%. I think it's more 95%.
Okay.
I think, but that's my personal
And there
opinion.
might be other things at play. I mean, even though
What's
normal,
that?
there might be other things at play as far as with implantation and many other.
Of course. I mean, so that's why you do your due diligence, and that's why, things like, for example, an autoimmune panel, we might even, suggest in some cases, even before a frozen embryo transfer, before even the first one, let's say the person is 40 and 41, 42, and we're not, we don't get a lot of embryos, and, we know we're not going to get any more potentially if they have diminished ovarian reserve, and we got one beautiful embryo frozen, or two maybe. You might want to do all these things proactively,
Mm-hmm.
and see and make sure. I mean, maybe it's a little overkill, but listen, I mean, you don't want to have to go back and kick yourself and find out that there was something there potentially that we could have intervened with or treated before we transferred that embryo.
And I know you recommend to do the nutritional recommendations and the acupuncture and the supplements, like give that time to work as well, even if they're
Sure.
cycle already, you've already done that part, or they've, already frozen the embryo, but it's still important to pay attention to what other lifestyle issues you can do in those 2 or 3 months prior to, that transfer, especially if
Yeah.
that's only
It's,
or you have like.
that's probably where it's more important is to see you at that time, because, we want stress-free lives. We're trying to achieve stress-free lives in people too. I mean, as much as we can do. I mean, everybody's so stressed out these days, understandably. But we've got to try to limit things, because, we're dealing with an embryo and a human life that we're bringing in. We've got to try to improve things so that this works, and that the person is healthy, and that by the time they get pregnant, they're going to be healthier in pregnancy. I mean, it's going to be a less of a complicated pregnancy. We don't want that either.
Yeah, sure that. So we've had a question about hormones. Where did it go? Okay, what if I have a regular period but still haven't gotten pregnant?
Well, you need an evaluation. I mean, there's could be other things going on. Um, Obviously a tubal issue, maybe. You need HSG. Check the tubes. You need to check your partner sperm count and see that the sperm looks adequate. Um, and see if professional and just go over your history and see potentially what could be going on. Maybe your timing is off. It could be anything. I mean, and it could also be unexplained infertility, which is about 20%, I think. 15% of couples have that, where we just don't know, from the basic testing what it could be. So, that would require obviously more investigation from a professional to see potentially what could be causing it and then what you should do next. And obviously your age, how long you're trying, versus, obviously if you're young, you could try longer, or, if you're over 35, you got to probably seek medical attention.
Yeah, definitely. If you don't want to be spinning your wheels if it's something that, for instance, like a thyroid issue or contributed by like low vitamin D and maybe a blocked tube, or there's some like little things that can trip you out. Not that that's little, but I mean, the little things that we can actually correct easier than,
Right.
maybe that
Sure.
difference, as well. So get the blood work done and the workup, and also the sperm test for the partner as well.
Sure. Absolutely. Simple things. Just start with simple things.
And basic things. And so I have a question here. What is a round of acupuncture for IVF like? Rough cost. Just started birth control to get ready for the first egg retrieval. So good luck. That is awesome that you're starting. And we work with our patients. We try to, during definitely the birth control phase, we're doing acupuncture. And sometimes, most of the time, we'll recommend even the month beforehand. So if we can have 2 months, that's awesome to do acupuncture. We don't always get that, but we do start with our patients usually who are going through IVF twice a week, 6 weeks prior to starting stimulation. So that's usually what we try to achieve. I mean, we don't always get that time, like you said, but if we do, then we definitely have measured the outcomes. We look at all of our outcomes for our patients, and the ones that have come at that treatment frequency have gotten better results than sometimes the ones that we don't see as often. So, and maybe you've seen that too, Dr. Gelman. I know that you definitely refer your patients for acupuncture to recommend that for them. So I think the stress also definitely gets better. With acupuncture, it seems like even if you're faced with the same stress, it just falls off easier. It's not that you don't care, but you just go like, oh, okay. I mean, it's not bothering me. No.
Yeah. That's a good thing. That's a good thing. Yeah.
And
because it's part of the whole plan. I mean, it's acupuncture. It's always acupuncture, healthy diet, yoga. We recommend a lot of things at once, and the people who really follow it just say, Doc, I feel so much better. I feel so much better. And they're also taking time for themselves.
Yeah.
Not working like maniacs all the time, and aging yourself.
Right.
And you're improving your outlook. So it's all part of the whole plan that's recommended, and it definitely works. It definitely works. There's no question.
Yeah, and I think more and more insurance is now covering acupuncture. So they asked about the cost. Medicare just last year approved acupuncture, which is major because it's been like 20 years in the works. So now that Medicare has approved acupuncture, I think a lot of the other the policies will start to follow.
That's usually what happens is
right.
Once Medicare approves it, then you'll get other insurances following suit.
Right.
So that's good.
We do work with some Medicaid patients as well. So there's definitely more broader coverage. If you don't have acupuncture coverage, we do have different plans because we know people are going through a lot. They're dealing with a lot of expenses, usually with IVF. So we try to make it very affordable to where someone can come more frequently than just one time or 2 times. So if you'd like that information, our office manager has that. So you can give us a call anytime, and our phone number is in our bio, or you can go to our website at floridacompletewellness.com and you can request a phone consult. We do like 15-minute phone consults. over the phone or in person, whatever you liked. Most people like to do virtual now. Consultations anyway. I know you do those too.
Yeah, I think they're great. I really enjoy them, actually.
Yeah, and we've had a lot of people come in who are needle phobic. They're absolutely scared of needles. Like they they can't
Yeah, a
do
lot of people say
they
that.
cry at the sight of a needle. So I'm like, wait, but you got to do IVF. I mean, this is they got to
But
get.
yeah, same thing with IVF. I mean, they say the same thing about the needles, and then they do their first shot, and that was it. You know, because the
Yeah,
needles now are so sharp, you don't feel them, and it's all sub-Q. I mean, many years ago, everything was intramuscularly, and that was
yeah,
painful.
yeah,
Not anymore.
yeah,
So
yeah. The progesterone is probably the one that people
that's the only one,
think about the most. Yeah.
pretty much. Yeah.
But as far as the treatment goes, I mean, I always explain it's like the size of your hair, the needle. It's 36 gauge, which is so tiny. So we usually start face down for the patients that are extremely needle phobic, and they don't even see the needle. And then we do hypnosis. So we hypnotize our patients with fertility hypnosis, meditations. We do a little essential oil. We try to help with their
No.
breathing. So there is a lot of anxiety
Great.
going into these cycles. We try to work with the mind because the mind controls the ovaries. Sometimes the brain has to communicate with the ovaries, and then the ovaries back to the brain. So there's a whole feedback loop that is how acupuncture works so well. And I think just doing sometimes the first treatment is so nerve-wracking. We actually had a patient who came in this week with her blood pressure through the roof because she was so nervous about the treatment. And after the treatment, it was like, oh, this is not a big deal. This was great. I fell asleep. So it just, it just basically getting to the point where you can say, okay, I'm going to give this a try, instead of being completely afraid. So we do see a lot of needle phobic patients, and they do actually a little better when the time comes to do the injections, because they see all those needles and they're not like as freaked out as they would be. So
Yeah.
so okay, and then there is another question in Spanish regarding financing for you guys. So I would say, and I'm sorry, I'm not great with Spanish, but I would say for that person, if they could contact your office, because we don't know anything about that.
No, we don't know anything about financing.
So that they can help if you go to
Yes.
ivfmd.com
Yes.
and talk to someone. And okay, and then next question is, does conception late in the cycle, 80 days plus, and they have PCOS, does that increase the chance of miscarriage? Okay, so they got pregnant 80 days into their cycle.
Not necessarily. I mean, that's when they ovulated. I mean, we know women with PCOS do that. As I said, the first part of the cycle, and that's a perfect example of somebody, is extremely variable. It can be very short to very long. That person had a very long, first part of the cycle until they ovulated spontaneously. They probably weren't even aware. And, so that's when it happened. No, that will not increase the risk of miscarriage. The miscarriage is due to probably most likely a chromosomal problem that happens to people with normal cycles or long cycles.
Yes, and it's with PCOS, it's like you don't ever know when you're going to ovulate, and so that's the hard part about PCOS. And so, and also it's nerve-wracking because you think maybe you're pregnant, not. And we had a patient come in who was 4 months pregnant and had no idea, and she had PCOS. So, I think like that's the hard part, but you do need a way to track your cycle somehow. So we know that like those LH strips don't work very well for PCOS sometimes, and if you have really long cycles, we try to encourage nutritional support, like with Avasitol and different things to actually help regulate the cycle a little bit more. Maybe they need to see someone to check their insulin and glucose, because that could also be a problem. And maybe they have to do medication or not to help regulate their glucose. But also work, with the lifestyle part, it's huge. And so with PCOS, so definitely it increases your chances, to get pregnant if you have more cycles. Obviously, if you only have a couple cycles a year, it's harder. But it's not going to increase the miscarriage rate if you do get pregnant, is what we're trying to say,
Right. But that's exactly what you do. But this patient obviously got pregnant. That's a good thing. But for the other ones out there, they should definitely get some assistance.
Yeah.
Because there's a lot of things we can do and help them track things more appropriately so it happens faster.
We do have a question now in the chat that any suggestions on how to get my period postpartum after nurse
for 17 months.
What was that?
Oh, is the person still nursing? I'm not sure. She said maybe she stopped nursing already, and she's trying to get her period back after nursing for 17 months.
Well, I think that's more of the gynecologist problem. But, check prolactin. Is the prolactin still high? Is there something else going on there? Does she have PCO? Is there another issue? I mean, could there be a hormonal problem that the pituitary is not working properly? Something's going on that needs to be checked.
Yeah, maybe it just takes a few months, because once you discontinue breastfeeding, it can take sometimes
takes several months sometimes, but not how long is that? A year and a half, a year?
If she was breastfeeding for a year and a half, it could take some time,
Yeah. Yeah. Oh, if she just stopped, then yeah, it's going to take.
We don't know how long it's been since you stopped, but your also frequency that you were breastfeeding, all those things are really,
Yeah.
That. So, but yeah, if nothing's happened, then for sure, like in 6 months, I'd say, like, get that blood work done.
Yeah, I would give it 3 to 6 months before, things aren't coming back. That's got to be looked at.
So these are great cycle questions we're getting
Yeah.
here. There's, okay, we have another question. Wife is 37 and he's 41. Have 2 kids, 11 and 5, have been trying for 2 years with no success. What's wrong?
How old are they?
The kids are 11 and 5.
No, not the kids. How old are the parents?
Okay. The wife is 37 and he's 41.
Yeah. That you need an evaluation. I mean, I think obviously maybe the wife has diminished ovarian reserve. So maybe it's getting a little harder because there's less eggs there. Don't know. I mean, obviously that's got to be looked at. Maybe there's a problem with the sperm count. Is the male in good health? Is there anything that happened to him?
It's a long time to try if you've had already children before.
So is this the same wife, same partner?
Yes, it looks like.
So it looks like they need an evaluation to see what it is.
Yeah.
Sounds a little unusual.
Yeah. Yeah. So
Usually see that with a new partner, like a second wife or a second husband.
Okay.
But I guess anything can happen. Maybe something did happen to them.
Yeah.
Medically.
Your body changes as you get older, for sure. So.
Yeah.
There is a question about thoughts on the COVID vaccine when trying to conceive. Not a frontline worker, but scared of COVID.
Yeah. I think you should be scared of COVID. I mean, I think we don't know a lot about its effect on fertility. There's been some very negative things that come out about it, affecting fertility and testicular tissue, et cetera, et cetera. So you want to try to avoid this thing at all costs. I mean, and well, it's going to be your decision whether to get the vaccine or not ultimately, because obviously everybody's in the same boat and we're all, a little nervous about getting it. And it's been worked on very quickly and came out very quickly. We don't know anything really long-term about it. It's the best thing we have, though, to prevent it. And, I think if you have the ability to get the vaccine, you should probably think about it very, cautiously about getting it and potentially think positive about it because, at least the societies, the OBGYN Society, the Reproductive Society, said it should, if it's offered, you should get it. And even if you're pregnant and lactating, you should get it. So, it's not been shown to interfere with your fertility. That's nonsense. But getting the virus might. Mm-hmm. So, even the men out there, if there are any men out there, you don't want to get this thing, and there's potentially some effects on testicular tissue. So you got to be careful. And I think I would try to get the vaccine, which hopefully in the next couple of months, everybody's going to be able to get it. Once this thing makes the rounds, I think the Johnson & Johnson vaccine is going to be available shortly. And that'll probably be in Publix and places like that, where it'll be much more readily available rather than, having to go through hospital systems, etc. that's what I think is going to happen. And you know, there's obviously other ones coming down the pike. But if you can get it, get it. That would be my advice. But you got to be comfortable, and it's got to be ultimately your decision.
Have you had yours yet?
I had mine.
Yeah, I did too. And honestly, I know people are like, wow, you got a vaccine, but we have different, everyone has different things. And my husband is compromised. He's got a kidney transplant. So he got his vaccine the same day I did, which was actually funny because we were both nauseous and achy and all that, and kind of had this arm pain on opposite arms. But
Yeah.
it was fine. Like a couple days later, I mean, I felt a little bit like I had a bad cold. But it was it. So, I mean, I think, yeah, we see the after effects. We're seeing patients coming in now who've already had COVID, and some of them are complaining of, like neurological things that are not good, like brain fog and difficulty concentrating, loss of taste, smell that lasts a very long time. Who knows what they're going to find the next few years. So we don't know. That's why. So I think that is a personal choice, but definitely it's one of those things you should talk about and figure out as far as your risk factor and if your exposure and all those things. But I think it's important.
Yeah, listen, I mean, I had this conversation, with people, and I had one with a pregnant patient the other day, and she was in she has the ability to work from home.
Yeah.
And stay home essentially and almost completely quarantine herself.
Mm-hmm.
I mean, not everybody has that availability to do that. So, I mean, if you have the ability to stay home and really stay, in that kind of situation, maybe wait and see. But I think that's also hard to do. I mean, you're going to isolate yourself to such a point now. I think that mental illness is going to increase.
I think it already has.
Sure. I think the psychiatrists are very busy these days. Mm-hmm. From all this. So it's not an easy answer. I think you have to feel this out and do what you feel comfortable doing. I think most of the medical professionals got it. And so maybe, I don't know if that gives you.
Well, we're all going to grow like foreheads,
So far, we're still here,
We're still here, right?
So and the side effects are really nothing. I mean, you get a little, everybody says, if you don't get side effects, the vaccine didn't work. That's nonsense.
Yeah.
So some people get side effects, some people don't.
Yeah. No, exactly that. So at the end of the day, evaluate what's right for you. And hopefully we are going to get through this. The numbers are looking way better. That's awesome. So,
yeah. It really is.
So as far as, I just passed. You're getting so many good comments. Thank you guys. Dr. Gelman, press the heart button, guys. He's awesome. You're getting a lot of compliments here.
Me or you?
Into this world. So that's awesome. And it looks like, okay, maybe I passed the question here, but okay. Can I think we already answered this one. One's lining be too thick? What problems can arise from having a thick lining? Well, I think we talked about this. You don't really have too thick of a lining, right?
Well, I assume that problem, that question was related to somebody about to get a transfer.
Right.
Because there are thick linings that have nothing to do with
that's true.
transfers. That's a problem. That's a separate problem. That's more of a gynecologic thing.
Right.
But so I assume that the answer they're looking for is in terms of, an embryo transfer or a frozen transfer.
Yeah. Right.
So that's,
too thick, you got a problem if it's chronically thick. That's not good.
Yeah, if it's a chronically thick problem, that's another whole issue.
And why don't the LH strips work for PCOS? You can explain too, but sometimes with PCOS, that LH is just elevated all the time. So
it's elevated all the time. It's one of the hormonal abnormalities in PCO is just an imbalance from the pituitary gland in terms of the output of those hormones, and the LH is usually elevated, not all the time, but usually. And a lot of people think they're ovulating because they're measuring LH. That's what you measure in your ovulation kits. and they get a little, a little bit of a surge there from the LH secretion, so they think they're ovulating. They're not. So we tell people not to use those kits, for that reason, especially in PCO.
Right. I like temperature charting. I know it's super old school, but I mean, at least for like really, really long cycles, if those belly strips are not working, I mean, I don't know. It can be helpful, at least.
Well, it tells you in retrospect. I mean,
Yeah.
it's not something that's going to tell you, right away that, you have, and you can do something proactively
Right.
from that. It's something that's happened already. So at least, you did it at some point, but you may have missed the mark.
Yeah.
But, in those situations where you're having crazy cycles like that, and, that's where you need help. I mean, you really get help. Ultrasound, Femara, Letrozole, those are great drugs for that.
Yes. And we have a single lady question. Hey, single lady. She's single, 32-year-old, getting interested in getting a sperm donor. How does the procedure work? So.
Well, when you come to a consultation with us, we're going to recommend you use only FDA approved sperm banks, of which there are several around the country. The prime ones we use are, California Cryobank in California. That's the biggest in the country. And Seattle, which is also a good one. And you can go on their websites, and they have, different availabilities of different people from, all different sizes and shapes and ethnicities available. And basically you just, pick your own donor, and they will, they have advisors too that can help you. You can reserve the sperm, so you have it there for multiple attempts. So you'll get all their information. Some of these guys are allowing the child, once I think they're 18, to contact them. They have these kinds of things going on now. So you'll get all that information on your particular donor. So, you do that independently of us, essentially, and just, when you're ready to do an insemination or whatever you're doing, you have the sperm, sent in a cryovac. It comes, sent to us directly, and they work with us all the time. So it's not an issue. And it's very easy to do, but, it is expensive. It's very expensive, donor sperm.
Yes, that's always a question of like IUI versus IVF, because
Yeah, that's always a big thing. And then, one of the new things, or one of the discussions we always have, is something called InvoCell now. It's a new device that, particularly for single people, lesbian couples, things like that, where donor sperm is going to have to be used. We would also recommend potentially an InvoCell, which is an in-between IVF and IUI. It's actually a little device, a little small device that actually donor sperm, in this case, and the woman's eggs would be placed in, and the woman would actually carry this little device for 5 days. And it's almost like an IUI, because fertilization will happen in this device. But you'll potentially make embryos, so that you'll have embryos, hopefully, if you're fertile and a good candidate for cryopreservation. So, maybe from one treatment of this and one vial of donor sperm instead of multiple vials of donor sperm, which is typically needed for IUI cycles, because IUI inseminations don't work that well. So there's multiple attempts. And that kind of feeds back to this article on the latest fertility journal. I think it was December. They had a pro and con. What should be the first line therapy, for people with unexplained infertility? Should be IUI or IVF? And, one guy was arguing, 5 or 6 attempts at IUI.
Wow,
but that's not necessarily with donor sperm either, because donor sperm is very expensive per month. So, and another fellow was arguing IVF should be first line because of its effectiveness. So this is an in between IVF and IUI, InvoCell. It's kind of cool. And I was even thinking that this thing when it came out was designed to be the next step, maybe for people who failed IUI that didn't want to quite go to a full IVF cycle, maybe. But actually, this is almost like a first line thing, really, potentially in single people or in people who, lesbian couples, for example, maybe want to do this because you can create embryos potentially.
With one vial? How
with,
many?
with one vial donor sperm.
Okay, that's pretty cool. Right?
Yeah, yeah.
Technology, what the things.
No, it's a brilliant idea. It really is. It's just, I think it's got to, be used more. And I think we've got to get a little more familiar with it. But it's a brilliant idea, I think.
We have another vaccine question. Is it safe to be pregnant and working with COVID-19 patients and not take the vaccine?
Ooh.
Oh man, I don't know.
Ooh, what was that one?
Okay, so we do have someone I think she must be a healthcare worker, or I'm not sure, but she said, yeah, is it safe to be pregnant and working with COVID-19 patients and not take the vaccine?
Not take the vaccine?
Mm.
Oh, boy, I wouldn't do that.
That's pretty, I mean, taking
that's pretty dangerous, I would think. I would not take any chances with that.
But I know where she's coming from because she's pregnant. There's no studies on pregnant women yet. I mean, I know that they're saying it's okay. We just don't know. I don't know.
I wouldn't take any chances. If it was me or my wife, I would not.
No.
I would try to work remotely.
Mm-hmm. Right. Yeah. Well, that would be. Okay, and then yeah. Do you recommend to take the vaccine before transfer? Oh yeah, timing for that. Like, what do you think? Like, if somebody is do it.
Well, I've had people do it. I mean, I think you got to do it when you get it offered to you. I mean, there may not be another choice.
Yeah.
You may be in the middle of this thing and get offered, and I think I would do it because, again, the societies say, they all came out. The choice is yours, though, that if you get the opportunity to get offered it, it's safe, and there's not been any problems with it in relation to fertility. So I would get it.
So should they time it where the second, like giving some, I guess, like a buffer zone between the transfer? Or, I mean, you don't want to do that right on top of the transfer, I guess you could say. I mean, if you had a choice, I guess, of when you could get it. Or
yeah, I mean, I wouldn't I certainly wouldn't do it the day you transfer, because that's the day you're going home and getting into bed or relaxing those days, But, a week or so before, sure.
And let's see, we've got, okay, that was all for the vaccine questions. What is the purpose of sperm binding test? Sperm binding test, maybe? Is it?
Well, that's looking at how well the sperm binds to like a sample egg membrane setup, so to speak. So it gives you an idea of, does the sperm bind to an egg membrane, for example, in natural IVF? What percentage of the sperm would bind versus, is it a low percentage because the sperm has a problem, it can't activate enough to bind to the egg membrane, so it has a low percentage of binding. So therefore, maybe we have to do more ICSI, where we take the sperm and kind of move it into the egg directly, because the sperm isn't doing the trick.
It says when all other parameters came back normal in the sperm analysis. So
yeah. Okay. Because the semen analysis, although it's pretty good an indicator of sperm function, may not always tell you everything, because the sperm could still be disrupted in a sperm chromatin structure assay. That's another test. Or a sperm binding study, it just doesn't activate, because the sperm has to fuse two membranes there before it actually fuses with an egg membrane. So maybe there's a defect there, so that the percentage doesn't bind, or there's some kind of sperm antibody problem or something like that, potentially maybe could be affecting how the actual IVF will happen. So maybe that person doesn't qualify for regular IVF as much and will need ICSI. But sometimes, they wash the sperm, if there's antibodies there, they wash them off. It depends on the problem, really. But it sounds as if that person might need, a little more hands-on kind of thing.
We have just a few more questions left. So we're going to be kind of wrapping it up soon. So any more questions, guys? But these are submitted earlier, so I want to make sure we answer them. The question is that this person has had 3 miscarriages, unfortunately, and 1 ectopic in 2020. All exams normal, natural killer cells too. What now is the best course of action?
Well, were they IVF related, or they were?
That's all I have here. I'm not sure.
Yeah.
Sure.
So we don't know, but if they were not IVF related, maybe PGT for that person to find out, are the chromosomes normal in the embryos and things like that. I would definitely do a thrombophilia evaluation, SIS, HSG. The natural killer cells, what did they do as far as that? They just did a natural killer cell level, or did they do a natural killer cell activity? Because the activity may be abnormal, or there may be excess cytokines. There's another blood test that looks at the cytokines, the chemicals these things make, that will tell us whether there's immunologic issues causing some of this. I mean, I don't think the ectopic had anything to do with the immunologic issue necessarily. But the 3 miscarriages might be immunologic, or they could be chromosomal. It's hard to know. So obviously, that person needs more an evaluation.
Yeah, it's definitely. It's very unfortunate, and hopefully you will get help and get a second opinion. Also, if you have been doing any kind of treatment,
yes,
heartbreaking. So as far as the questions for, we have one more lining question actually, kind of tie this in here. Someone is asking, why was my lining less than 4 millimeters with dial valerate?
What was that again?
Oh, why was her lining less than 4.4 millimeters while she was on estradiol?
That's pretty thin. Yeah, those are problem patients. And who knows why that is? I mean, did that? And that goes back to your DNC questions, because actually I should have mentioned that, is that sometimes a rough DNC will scrape off part of the endometrium that because the endometrium regrows every month. Sometimes they're too rough and it scrapes off what's called the basal cells, the basalis layer, and those people can't develop a thick lining anymore. They have a very, very thin endometrial lining. So, that goes back to a rough DNC, but if this person didn't have it, that's a tough problem. That we try everything with that. Viagra suppositories and, double the estrogen, triple the estrogen. We even try Neupogen infusions in there to see if, these growth factors that we put in there will thicken the lining. Sometimes we've had variable success. Now, I've had several cases over the years, and one of them involved doing an ERA on a person like that, where we got her lining barely to 6. Barely to 6. I remember this case now. And I did an ERA biopsy, and it came back that she was pre-receptive, which means, hey, we probably have enough estrogen in there, but we just need more progesterone.
Okay.
And they gave us the amount of hours extra. So we did that, we transferred, and she got pregnant. So it was barely at 6. And I remember this like yesterday. But 4 is a totally different animal here. And again, I think that's going to require a lot of different trial and error on different things there to try to thicken that as much as possible, and find out also if you've got a problem in there, like you had a rough DNC or something like that, maybe a hysteroscopy in that person to kind of look in there and see what's going on there, so you have a better idea what you're treating.
And I would also ask if there's been a lot of cardio or exercise involved, because I've seen over the years some patients that are over-exercising have issues with their lining, and we try to do electric.
Yeah, if they in a natural cycle, but you know, if you're giving them hormones, you should think that should thicken, you know.
Mm-hmm.
But in patients like that where it doesn't, that's some kind of blood flow problem potentially,
Right.
or there's a lack of lining in there. Something else is going on. There's something's not responding to the hormones that person's being given.
Yes, ask
So
your acupuncturist to do electroacupuncture. That actually has been proven to be more successful than typical regular acupuncture for lining issues. So,
yeah.
look you up. So, and then another question is, okay, first Letrozole cycle successful, ended up in a miscarriage. Second one failed with 2 eggs. Is there another follow-up to that? Okay, I mean, there's not a follow-up question, but I would guess that, yeah, it's not related, but I would say that is you probably need to seek more testing, I guess. I mean, the first, if there's been two miscarriages, I guess. So, so hopefully definitely get some evaluations on if, I guess they are, since they're on Letrozole, but it could be with a fertility clinic or it could be with a gynecologist. I mean, so.
Well, that person just had a Letrozole cycle and got pregnant the first time, but miscarried?
Yeah. Yes, exactly.
And
Yeah.
then the second time she had 2 follicles and did not get pregnant.
Right.
Right?
Mm-hmm,
Yeah. That's not unusual. I mean, that happens. I mean, it's, you know, just because there's 2 there doesn't guarantee you're going to get pregnant either. And, you know, again, you know, Letrozole is a good drug and, you know, we use it an awful lot. But, you know, statistics aren't tremendously great just with Letrozole and, you know, either time intercourse or IUI. It's not great. It's probably 18%. So hang in there. Keep going if, you know,
yes,
don't get discouraged.
really hard. And I mean, hopefully, we wish you all, everyone on this live, all the success in the world. And if there's anything that can help you, we will help you. But I definitely get a second pair of eyes if you haven't already. Talk to Dr. Gelman if you have questions, more questions, because we only have time. We're wrapping it up right now. We've answered questions we can tonight, but definitely we'll be back with Dr. Gelman next month. We are here to answer anything that you need answered, and also if we didn't have time to get to it, he does have virtual consultations as well.
All the time. Yeah, we do them all the time. We love them. I enjoy them. So please schedule, and you can just stay in the comfort of your house and we can talk.
Yeah. We have 2 more questions. We're going to get those in. Okay, so how many eggs do you typically try to retrieve for IVF with PCOS patients?
Well, typically we get a lot, you know, sometimes 20, 30, 40, 50. I think I've got 60 once. A lot of them, unfortunately, are immature, you know, because PCO, that's the problem with PCO. You don't mature your eggs very well. But, you know, we're typically going to get a lot of them, but, you know, half probably are immature. So, you know, if we get, you know, 15 to 20, you know, of those, it's hard to know how many we're going to actually fertilize and actually going to make embryos. But it's always a lot of eggs. It's always a lot of eggs, particularly in younger ones.
And what's the average retrieval of eggs with a 32-year-old patient with PCOS and a good AMH?
What's a good AMH? You know, again, it's the same question, I think. We may get 15, 20, 25, 30, could be more. But again, what's the maturity of those eggs? How many of those eggs are going to fertilize? And, you know, how good was your stimulation? Were you hyperstimulated at the end and things like that because we needed to mature the eggs so much? You know, so a lot of that's going to depend upon the person itself and, you know, what the clinical situation, you know, mandates. But typically it's all over the place. We do get a lot of eggs, but a lot are immature.
We're getting 2 more questions. They're sneaking them in, right? Yeah. Okay. Hi, after 2 failed FETs in a 28-year-old, what's recommended besides ERA and biopsy of the uterus?
Yeah, I would look at your immune system. I would be looking at NK activity and, you know, APA and, you know, things like that, thrombophilia stuff. You know, your lining, assuming your lining was appropriately thickened, the ERA is definitely something you would do. As part of the ERA, we do something called the EIP, which is an endometrial immune profile. I do that, where we look at, I guess, production of abnormal cytokines inside the lining during a mock cycle. So it gives us an idea that there are, natural killer cell activation going on in there abnormally, in a sense. So sometimes the blood test may not show you that, but we'll find it on the EIP or vice versa. So we'll know. And, sometimes we don't always know what causes failures. Assuming those are PGT normal embryos, sometimes we don't always know. We can do all these tests, and yet it still doesn't work. So sometimes we have to take the bull by the horns and, play doctor and say, you know what, we're going to give you an empiric dose of intralipids or Lovenox or prednisone and just treat you empirically, because we don't know for sure what it is, but we have an idea potentially what could happen once your body recognizes part of the pregnancy being foreign. Maybe there's some immune activation that happens at that time. So we'll treat you empirically, and it works.
Yes, I've seen it many, many times.
Yeah.
So don't give up.
Yeah. Yeah.
And last question, guys. What could be the reason of fluid in the endometrial cavity during natural cycle? No hydrosalpinx, no endometriosis, no ismosal. Did I say that right? What could be the reason of fluid in the endometrial cavity? Yes.
Is this during a frozen preparation?
Natural. Yeah, just natural.
A natural cycle. Well, it could be mucus. Maybe it's abnormal mucus in there. We can aspirate that and look at it. So, and see exactly what it is, but that's probably what it is if it's truly a natural cycle. But yes, in other situations, in frozen transfers, if somebody's got a hydrosalpinx, that's what you'll see is fluid in the lining. Something like that abnormally. But in this situation, it's probably mucus, I would think. Due to, thinning of the mucus due to the estrogen stimulation of the cervical mucus. So it you see it in the cavity sometimes.
Interesting. Hey, I always. Okay, the mucus it says the mucus has inflammation. Can it cause inflammation? The mucus.
Yes.
I would think.
Yeah.
It's probably not great for implantation, right? I don't think.
Yeah, sure. That could cause a problem for implantation. So if there's some kind of infection in there, that's got to be treated.
Thank you, Miss April Flowers. We love you too. And I think you guys.
Not April yet.
Thank you for letting us pick your brain again, Dr. Gelman. Have a great week, everybody.
You
and
too.
We look forward to next time. Share it with your friends, and also follow Dr. Gelman. You're at the Broward Fertility Expert, right?
Right.
Okay.
Right.
And follow us at FL Complete Wellness. So thank you guys. Have a good night. Bye, everyone.
Great night. Bye night.
Bye.